I'd like to invite Dr. Mairéad McNamara now up to give her talk on the microbiome, what we think is important in cholangiocarcinoma and the ABC12 study. Thank you, Dr. McNamara.
Okay, thank you. And good afternoon. As these are my disclosures. So what I'm going to do, I'm giving an overview of what I'll do today. I'll talk about the definitions, just a little bit about what microbiome means, microbiota, diversity. You'll hear all these words when people are talking about the microbiome. I'll talk about the normal gut, how it is and how it works, and a little bit then how it's relevant to hepatobiliary cancers. I'll then talk about what are the potential therapies based on what we know about the microbiome, and then I'll summarize. So Prof. Khan already mentioned this, but microbiota, just what it is. So it's all the microorganisms found in the environment. So these include the bacteria, viruses, and fungi. So that's microbiota. Then what microbiome is, it's the collection of the genomes of all those microorganisms. And then if you hear about dysbiosis, you're talking about an altered gut microbiome. So you have microbiota, microbiome, and then dysbiosis, where you have an alteration in the gut microbiome. Then you'll hear things like diversity. So what does that mean? Diversity, if you think about it, it means lots of different types of things. So alpha diversity is the different microorganisms within one sample. Then beta diversity is the diversity between the different samples. And then gamma diversity is overall species diversity across communities. So I have some illustrations to explain this a little bit more clearly. So if you see, this is one sample. Within this sample, every figure that's here, it represents a microbial species. So the alpha diversity of this sample is 6. So there's 6 different microbial species in that sample. This is a second sample, so sample B. Again, you have 6 different microbial species. So the alpha diversity there is 6. So the alpha diversity is similar between those two samples. If you have a third sample, then sample C. So in this sample, you have 3 different types of microbial species. So the alpha diversity is greater in sample A and sample B than sample C. So then what is beta diversity? So beta diversity is the difference between one sample and another sample. So sample A and sample C, if you look at these. So the beta diversity then is the unique differences, the unique microbes between those two. So if you see from sample A to sample C, there are 2 figures which you see in both samples, so the cube and the half moon. So those are excluded when you're counting the beta diversity. So then the others that are left over make up the beta diversity. So there's 5 unique different microbes there. So that just gives, I suppose, an example of what diversity is, because I'll be talking about that a little bit further on. And then gamma diversity is the unique microbial species in the 3 different samples. So it's any ones that are repeated are not counted in that. It's the unique microbial species is the gamma diversity. So what about the normal gut? How does it work? So there are certain bacterial species, and these are just examples, Clostridium and Bacteroides, which maintain the gut homeostasis. So this is where the host functions that control the microbial growth are normal. So Clostridium and Bacteroides. And how do they do that? What they do is those particular bacteria break down fiber and produce short-chain fatty acids. They have anti-inflammatory properties. So they're good bacteria. And what they need to feed on is fiber in order to make the short-chain fatty acids, which have anti-inflammatory properties. So what they have shown in different types of cancers, they've looked at different types of cancers then. And for example, in pancreas cancer, they have shown that high tumor microbial diversity, so the more different types of microbial species you have, the better it is in terms of survival. And they also have looked at melanoma, non-small cell lung cancer, and renal cell carcinoma. And patients who have immunotherapy, the greater diversity in their microbial species, the better their response to immunotherapy. So this is in different types of cancer. This is not bile duct cancer, but I will come on to that. But with immunotherapy, we know in most different disease types, the response rate is not for everyone, about 20 to 60%. So response rate means that the overall size of the tumors decreases by 30% or more. So that's what response rate is. So these are different types of cancers, but I'm going to come on now onto bile duct cancer. So if you have an altered gut microbiome, so this is the genomes in the microbial species, if you have dysbiosis, which is the alteration, it can generate an immunosuppressive environment and is associated with the development of chronic liver disease, liver fibrosis, cirrhosis, and liver cancer, including cholangiocarcinoma. So if you have dysbiosis or alteration in your microbial species. So what do we know in bile duct cancer? So this was just a retrospective study, and it was a small study. It included 35 patients with bile duct cancer. It included patients with primary liver cancer as well. There was stool samples, so bowel motion samples taken before immunotherapy. And they found, so on the left-hand side, the patients who had clinical response had increase of different types of bacteria, whereas those on the right-hand side who didn't have response, they had different types of bacteria. So the ones with the clinical response then had better overall survival and progression-free survival. So that means the time to when the treatment stopped working. So we know that there are certain microbes that may be associated with better responses and with better survival. And they also found the higher the diversity and abundance of the gut microbiota was associated with less immune-related adverse events. So what about immunotherapy then in biliary tract cancer? So there have been 2 clinical trials recently. I'll show you the graphs, but it's just to take in a little bit about the response rate I want you to focus on mostly. So the first one was called the TOPAZ-1 trial, and patients received cisplatin gemcitabine with durvalumab versus chemotherapy alone. So the purple line represents those patients who received the immunotherapy with chemotherapy, whereas the brown line represents the cisplatin gemcitabine. So from this trial, the overall survival, so how long patients lived, was better for the immunotherapy combined with chemotherapy, with a response rate of 26.7%. So about a quarter of patients are only responding to the combination of chemotherapy with immunotherapy. But what is particularly notable in these trials is that at 2 years, so if you look on the x-axis, time from randomization, and if you come over to 24 months, twice as many patients are alive at 2 years in the patients who received the immunotherapy with chemotherapy. So what we don't know is, who are those patients? Can we identify those? And if we can, and find potentially that there's something different in their microbiome, can we help the patients that are not responding then to respond? So Keynote 966 was the other trial where they looked at immunotherapy, a different type of immunotherapy, pembrolizumab, and the results were very similar in terms of overall survival, how long patients lived, and in terms of response rate, with a response rate of 29%. So I'm coming on now to ABC-12. So this is the trial that is running within the UK. And what we're doing is we're looking to see if we can predict the patients who would respond better to the immunotherapy with chemotherapy. So this has been run in conjunction with the Wales Clinical Trials Unit. And patients are receiving, 70 patients are going to be recruited in 10 UK sites. Patients have bile duct cancer. They will receive cisplatin gemcitabine durvalumab. They will give saliva sample and a stool sample at baseline and again at 18 weeks. And what we're looking at, the primary thing is to see the difference in the alpha diversity, so that's the number of microbial species within the samples, between responders and non-responders at 18 weeks. So these are the sites within the UK which will be running the trial. There are 6 sites open now: the Christie in Manchester, Clatterbridge in Liverpool, Birmingham, Nottingham, Cambridge and Imperial College. And there are 4 different sites still to open, and they're in setup. So why is it important then to know what the microbiome is, and what is the difference between responders, non-responders, and what can you do about it? So there are things called microbiome-based therapies. So in the center is the name microbiome-based therapy. So the different microbiome-based therapies. On the top, you have probiotics. The green, you have prebiotics. Then the blue below, microbiome-derived metabolites. And then over in the purple, the fecal microbiota transplantation. So the probiotics are things we all know. These are things that potentially improve the good bacteria in the system. So fermented dairy products like yogurt is a probiotic, lean animal protein and omega-3 fatty acids. Then prebiotics, honey, fruit and vegetables and oats. And then the microbiota-derived metabolites, then, these are the short-chain fatty acids, which I said they're produced by bacteria which break down fiber. Can you use these as supplementations for patients? And then the other thing is, what about fecal microbiota transplantation? So it has been shown in different types, inflammatory bowel disease and other different diagnoses, that if you implant bacterial community from the stool into recipients, then they could potentially improve their response or immune response. So that has been shown. But what is more, I suppose, something that has come out very recently in a science paper is they looked at this in mice and they looked at it in humans, and they found that vitamin D can increase the gut bacteroidase, and bacteroidase, as I mentioned before, increases the production of short-chain fatty acids by breaking down fiber and causes an anti-inflammatory response. And they found that there was increased response to immunotherapy in these patients who had higher vitamin D levels. So what about manipulation then of the gut microbiome? So there, I have mentioned what the potential therapies are. Can you actually manipulate the gut microbiome? And this has been looked at in inflammatory bowel disease. That it was a pilot study, and they found avoidance of adverse foods like low-fiber diets and processed foods, and increased the prebiotics like high fibers shifted the microbiome, and then it led to production of more short-chain fatty acids and anti-inflammatory properties. Just in terms of medications, there are some medications that affect the microbiome as we would expect. Antibiotics do this, steroids, proton pump inhibitors, but these are necessary, and it is about, I suppose, trying to restore your microbiome if you have been on antibiotics. But has been shown that, as you know, sometimes people get thrush, so it's a fungal overgrowth because they're getting rid of some of the normal gut flora with antibiotics. So what about the future then? So this was a recent study which has been published where they found that actually there's possibly a signature of microbes which might indicate better response to immunotherapy. So this is something that has been looked at the moment. If it's not just one particular microbe, but many different microbial species, and if a particular signature, if you have 1, 2, and 3, that potentially you do better. So just to summarize then, the gut microbiome, as I said, it mediates the host immune system. High microbial diversity is good, so the greater the number of different types of bacteria you have, the better. They produce short-chain fatty acids and have anti-inflammatory properties. The gut microbiome is associated with clinical response to immunotherapy in different types of cancers, and possibly with biliary tract cancer as well. And what we're doing at the moment in ABC 12 is looking at this in a prospective fashion. We're recruiting patients and collecting samples as we go along. And then if you find out which microbial species are the ones that help patients more, then you potentially can use gut microbiome-based therapies, such as prebiotics, the yogurts, and the lean meat, and then use fiber-rich foods, avoiding low-fiber diets and processed foods, consumption of probiotics, fecal microbiota transplantation, and potentially supplementation of microbiota-derived metabolites. And thank you.